Hello, listeners. From the RSNA, this is the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath, and I am a radiologist from Dallas, Texas. In this podcast, we explore research advances and technical developments in cardiothoracic imaging through conversations with our authors, our editors, and experts in the field. Enjoy! Are you seeking the skills to critically evaluate and successfully integrate AI solutions into your everyday workflows? This new RSNA Spotlight course, Implementing and Evaluating AI for Radiology, connects you with radiology leaders who have implemented these AI solutions to help you make informed choices. Experience all the interactive benefits of attending an in-person session, but with a manageable time commitment in 2 convenient and concise live online sessions on March 14th and March 21st. Learn more and register at rsna.org/spotlight. Welcome back, listeners. I am now joined by the lead and senior authors of our featured paper. I would like to welcome Drs. Aishwarya Gulati, Dr. Behzad Pavri, and Dr. Baskaran Sundaram. Thank you all for coming on board.
Thank you for inviting us.
Happy to be here.
It's really great to be here. Thank you.
Thank you all again. Before we begin talking about the featured paper, I'd like to learn a bit about each of y'all. So let's talk about where y'all are working currently, what your current position is, and what are your academic areas of interest. Aishwarya, why don't we start with you?
I am currently a musculoskeletal radiology fellow at Thomas Jefferson University in Philadelphia. I also did my residency here. And during my last couple of years of residency, I was very interested in body and cardiothoracic imaging, as well as MSK, which is kind of what prompted me to spend a lot of elective time in cardiothoracic imaging with Dr. Sundaram, which led to this project.
Excellent. I think that's a good segue into Dr. Sundaram. Baskaran?
Hello, everybody. I'm Baskaran Sundaram. I'm a cardiothoracic radiologist at Thomas Jefferson University for the past 10 years. Did my medical education back in India, and then did radiology training in England and some additional radiology training in University of Michigan, and then stayed on there as a faculty member for 12 years, and then came to Philadelphia to join Jefferson Health. I'm here for the past 10 years, and my imaging area of expertise is the cardiothoracic imaging findings, clinical features, and clinical outcomes related to those findings.
Excellent. Thank you, Baskaran. And Behzad, how about you?
Yes, I'm Behzad Pavri. I am professor of medicine and director of the Electrophysiology Fellowship Program at Jefferson. I've been here for 21 years. I went to medical school in India. I did my subsequent training in the United States at Columbia and Harvard. I was an attending at University of Pennsylvania, and now I have been at Jefferson for 21 years. So I'm happy to be part of this project. My areas of interest are, of course, education and electrophysiology, and mitral annular disjunction has recently become an area of interest as more data emerges on this field.
Excellent. We have a very esteemed multidisciplinary panel here to discuss exactly what Behzad was referring to, mitral annular disjunction. That is the topic that was the focus of y'all's review paper that was published in the journal. Let's start by defining what mitral annular disjunction is. Do we have a consensus definition? Aishwarya, Ash, why don't we start with you?
Beyond the definition that it is the atrial displacement of the attachment site of the annulus, there is really no clear consensus. There's no minimum distance required to diagnose MAD or conclusive data on what may or may not be clinically relevant.
Behzad, can you speak to what we think of in terms of the pragmatic understanding or pragmatic definition of mitral annular disjunction?
As Ash indicated, this is an area of evolving understanding. Initially, any displacement of the annulus from its ventricular attachment was considered to be mitral annular disjunction, an abnormal finding. But it's becoming increasingly clear that there are many normal hearts that may have some degree of displacement. And, up to 5 millimeters is probably not very pathologic and may be seen in a large number of patients. Certainly, autopsy findings and in vivo imaging findings in healthy patients identify some degree of annular disjunction that may involve a significant circumference of the mitral annulus in many patients. So I think that we are now beginning to recognize that just some displacement by itself is not necessarily abnormal or pathologic, but it has to be associated with some other findings that we'll dive into that make it a more concerning entity.
You mentioned at autopsy. I want to go into now when we first identified this, and we can talk about not just imaging, but also pathologic discussions of when mitral annular disjunction was first described, and really how our understanding has evolved since. Baskaran, why don't we start with you?
Sure. The mitral annular disjunction, the term was coined in 1986. Before that, different researchers reported different things describing the same entity with things like atrioventricular decoupling, subvalvular mitral membrane. So there are different terminologies existent. But I think 1976 is when what it looks like is a initial description of the what it sounds like a mitral annular disjunction. There's a group of researchers looked at about 50 patients, 47 patients to be exact, of echocardiography, and then they reported something that looks like an atypical mitral annular motion. And then they observed it in about maybe half of those patients, and then they called it as atrioannuloventricular decoupling. And then 5 years later, a pathologist, Dr. Bharti from Chicago, described this condition. I think she described a case report of a sudden death. I think the patient who died was himself as a physician. And then she described the clinical features, electrocardiography, and pathologic analysis, histological analysis. And then she described the condition as the atrial migration of mitral annulus as the likely cause of this death. 5 years later, there's another group of researchers looked at 900 adult autopsies, and then they observed the abnormal annulus formation in about 65 of those 900 patients. And they described that condition as the mitral annular disjunction. So that's how the mitral annular disjunction came about.
Now, this is something that we, I guess, have described since the 70s to 80s, but obviously has existed since humankind has existed. Why is it that we only recognized it at that time? Is it just because the imaging technology or the pathology studies were focused on that? And furthermore, have we learned anything more since that time about the pathologic entity of mitral annular disjunction? Behzad, why don't you comment on that?
So I'm not exactly clear as to why it wasn't picked up earlier, but I think that it's probably related to the superb imaging that is available in today's world of medicine. In the past, it had to be really post-mortem analysis, but with the advent of echocardiography and then refined imaging with CT and MRI, these relatively uncommon conditions have come more to light. And the pathology of it has become more well described as people have started to put together associations of sudden death or recurrent syncope or abnormal heart rhythms. And then investigation led to the discovery of this mitral annular disjunction in association with that kind of clinical presentation. Dr. John Barlow is credited with the Barlow of arrhythmogenic valve description in South Africa, and he worked tirelessly to better study the mitral valve. He was a wonderful and astute clinician, and one of his most famous patients was Nelson Mandela. But that is the sort of evolution of understanding, initially from a pathologic description, then to imaging description, and then to correlation with adverse clinical outcomes.
I think that brings us nicely into that discussion of its impact on clinical outcomes. So, Behzad, let's dive into this a little further. What is the association between annular disjunction and frank mitral valve prolapse? And can patients have annular disjunction without prolapse?
So they often, but not always, go together. Certainly, it is very well described that some patients will have disjunction without prolapse. That's a minority. Many patients will have prolapse without disjunction. That's not uncommon at all. And then a subset will have both. And that is where we think that the risk may be greatest. The arrhythmogenic mitral valve complex is comprised of bileaflet prolapse with very floppy myxomatous degeneration of the leaflet tissue. subvalvular apparatus is elongated and stretched out with chord A. And because of this abnormal positioning of the valve apparatus and the degree of prolapse, with every heartbeat, there's abnormal tugging of the papillary muscles that over time results in scarring. And that scarring is the substrate for ventricular arrhythmias. Scarring is beautifully identified by what Ash and Dr. Baskaran do, which is imaging, and they pick up the burden of late gadolinium enhancement, which identifies the burden of scar. The papillary muscles are the apparatus that hold down the fronds of the mitral valve to prevent it from blowing out into the atrium with each ventricular systolic event. And the pap muscles actually pre-tense. That is why the left bundle branch has two fascicles, the anterior and the posterior, and they go to the base of each papillary muscle so that the pap muscles are tensed early on during ventricular systole to prevent the mitral valve from blowing out into the atrium with each heartbeat. It's a beautiful evolutionary achievement that prevents regurgitant volume into the atrium and establishes forward only flow. But with the disjunction and the tilting of the valve, that scarring that occurs in the papillary muscles over time can be the nidus for ventricular rhythm disturbances.
So I presume those are the most common adverse clinical outcomes that are associated with mitral annular disjunction, is those affiliated with ventricular tachyarrhythmias. Is it common to have ventricular arrhythmias with patients that have, say, incidentally identified annular disjunction? And how robust are the data supporting that association between bad outcomes and annular disjunction?
So this is again a topic in evolution. We're beginning to understand more. It's probably a spectrum. Early on in the disease, you might see very few PVCs. So for instance, now I am following a group of patients who have well documented MAD of up to 10, 12 millimeters and who have frequent PVCs but have had no clinical events, and they have traced to mild mitral regurgitation. What do I do for that patient? Nothing except monitor them, maybe consider placing a loop recorder to look for more malignant arrhythmias. As the disease evolves, the burden of ventricular ectopy may increase, and you may start to see more complex ventricular rhythm disturbances. Again, there we don't exactly know what to do in asymptomatic patients, but you might see runs of non-sustained VT. Later in clinic today, I'm going to be seeing a patient who has on her Holter bidirectional VT, something that has never been described, alternating QRS complexes on a Holter. And I'm worried about her, but she has no symptoms and has never had syncope. And so I'm not sure exactly how to proceed. I'm going to recommend a loop recorder. There are some data about ablating frequent ventricular ectopy, and then if the degree of mitral regurgitation worsens, then they need surgery. And surgery may be the best fix for it, but again, this has not been proven. The surgeon can correct the disjunction, correct the mitral valve leakage, restore the appropriate chordal length, and that may impact on better outcomes, but that has yet to be proven. So we don't have any good prospective data to tell us. This is really an entity in evolution in terms of our understanding.
Behzad, I think this was a great review of our current clinical understanding of this clearly very complicated and somewhat poorly understood entity that we're building more and more knowledge behind. A significant part of which, as you had mentioned, is imaging. We want to get high fidelity images, both by echocardiography, cardiac MRI, and other modalities, to understand the complex dynamics of the mitral valvular apparatus. With that in mind, I want to now talk about some cardiac MR manifestations of this disease. So many of our audience members are cardiac MR practitioners, but would certainly benefit from insight from your expertise on how to perform high quality cardiac MR to identify this diagnosis or affiliated abnormalities. For example, substrate that may cause these ventricular arrhythmogenic phenomena. Baskaran, can you start describing to us a couple of tips and tricks to optimize cardiac MR image acquisition when trying to characterize mitral disease in general or annular disjunction specifically?
Yeah, there's a guidelines from Society of Cardiac MRI that SCMR guidelines talks about how do we tailor cardiac MRI for patients with suspected mitral valve disease. The recommendation is that contiguous slices of 5 millimeter thick sections in all long axis planes, so 2-chamber, 3-chamber, 4-chamber of left ventricle and covering the entire mitral valve apparatus without any gaps. So it has to be a bright blood cine sequences imaging. So to evaluate the mitral valve, you really need to look at the entire cardiac cycle. Because case in point now here is the mitral annular disjunction. To evaluate that, you may be just seeing that during the ventricular systole and not during diastole. To understand the morphological alterations of the mitral valve during the cardiac cycle, for example, single leaflet prolapse or bileaflet prolapse, the actual prolapse height, the degree of turbulence. So all those things can be appreciated during the entire cardiac cycle. So I think that's the way we look at the functional and anatomical changes of mitral valve. For delayed enhancement, and that's one of the key part of the cardiac MRI in evaluating these patients with mitral annular disjunction, is something that we pay a lot of attention, of phase-sensitive inversion recovery, both phase and magnitude of specific imaging, to look at the ventricular myocardium, subvalvular myocardium, to understand the delayed enhancement, to make sure that what we are seeing in short axis images is not really partial voluming averaging from the blood pool from the left atrium or the adjacent coronary sinus. So you really have to look at that in multiple planes to really understand that it is really a finding that's something that's worth reporting.
Ash, could you walk us through how you would characterize mitral annular disjunction when seen on a cardiac MR, as well as what other abnormalities to look for? We have been mentioning late gadolinium enhancement. Where specifically are you tailoring your focus, and what are the common manifestations of LGE that are affiliated with MAD?
So, the first thing when evaluating for mitral annular disjunction is actually measuring the MAD distance. So, in the systolic phase, it can be a little exaggerated. That's why Dr. Sundaram was mentioning that it's important to evaluate the entire cycle. Typically, we do measure it in the systolic phase in the three chamber view. Once we have a distance, it's also important to recognize some mimics that can give you the false impression of MAD, such as what is called pseudomad, which is when the prolapsing leaflet sort of sticks up along the wall. So it looks like the valve is arising from a higher point than it actually is, which is why, again, we rely on the cine images to make sure that we are dealing with true MAD before we go into like measurements and the other details. Late gadolinium enhancement is definitely a really important finding to be looking for because a lot of studies have also shown that MAD is more clinically relevant when associated with a constellation of findings. One of the more important ones is LGE. So, LGE typically you'll see in the papillary muscles, the posterobasal LV myocardium. Other things to look for is going to be the LV diameter. Usually, the LV diameter, particularly in younger patients with MAD, is found to be increased, and it is more likely to be symptomatic in those cases. The annular diameter as well is typically increased in these patients. Having a constellation of imaging findings is more likely to be clinically relevant than the isolated finding of MAD.
This is great. And I must say that a lot of places where I read cardiac MR for, and probably many of our listeners, will have a kind of out of the box routine protocol. There's not one that is tailored specifically for the mitral valve. So when we identify annular disjunction and its associated complications, it's done so incidentally. Are there any modifications to the routine image acquisition protocols that you would suggest when we know in advance that a patient has annular disjunction, perhaps identified by echocardiography? For example, I often find difficulties in temporal resolution with some of our bright blood imaging, or even our late gadolinium enhancement imaging. I have not necessarily done anything beyond single shot imaging at certain institutions, and the image signal to noise is not as robust to pick up those small areas of LGE. Do y'all modify your routine protocols?
Yeah, when we know ahead of time this patient has unexplained cardiac arrhythmia and mitral valve, significant mitral valve incompetence or mitral valve prolapse, then we tailor our sequences to cover the entire mitral valve apparatus. Otherwise, we are really getting maybe a couple of slices through the mitral valve and the other valve. So just to make sure that we get through the scan quickly. If we know ahead of time, we would try to make sure that we cover the entire mitral valve apparatus on all cine-bright blood imaging, specifically with 5 millimeter thick sections without any gaps. And then in terms of late gallium enhancement, we do both single shot imaging and phase sensitive inversion recovery imaging. We specifically just do phase inversion recovery single shot imaging in patients who have breath holding ability and they want to get out of the scanner. So that's why we do that. But we try to have both set of sequences on all patients if possible. And if the patients really want to get out of the scanner, we'll try to talk to the patient at least to get one set of images through the mitral valve. That's how we tailor it. You're absolutely right. If you don't get good enough temporal resolution, let's say less than 50 or 45 milliseconds, it's really difficult to appreciate the anatomical alterations in these images. There'll be a lot of skips that we'll be dealing with, and we won't know how to interpret this imaging. And then in terms of slice thickness for LGE, again, I would just use 5 millimeter thick sections without any gaps in between. So that's another way we do it. And it's really key to look at both long axis and short axis to make sure that you're not mistaking something that should be normal or just a variation that should be considered as, should be really abnormal. We want to look at that. When you're looking at the mitral annular disjunction, when you're looking at the prolapse, it's very commonly we see these patients with mitral valve prolapse and mitral annular disjunction together. When we see it, we got to make sure, as Ash mentioned, it's important to make sure that we are not looking at pseudomat. It's very easily the prolapsing posterior leaflet can fold along the atrial wall, and we got to make sure that that's not called as mitral annular disjunction. Imaging is great, but it's not. It doesn't have very high correlation, very high pathological confirmation. So I think it's something that you got to be very careful when you're calling these MAD as really truly mitral annular disjunction. And there are other things in patients who have prior mitral valve surgery who has subvalvular aneurysm due to either endocarditis or postoperative complications. So those patients can also look like a mitral annular disjunction. It's really important to correlate that clinically to make sure that it is not that we are mistaking for mitral annular disjunction.
I think this has been a great review of the imaging findings of mitral annular disjunction and its associated phenomena. Before we close the conversation, I want to talk about what we would like to see in the future understanding of this very complicated disease entity, both from the imaging side as well as from the clinical side. Ash, why don't we start with you?
I think the first thing that we need is a clear definition. There is so much variability in the data that we have because each study defined it differently. There's no minimum distance that has been defined. So the clinical implications that we're associating with this are also very varied across this spectrum. So the first thing that we would need, I think, is a definition that comes together from, a whole multidisciplinary group.
Nice. Thanks, Ash. Baskaran?
Absolutely. I think it's even though it's gaining speed in understanding and recognizing and understanding this entity, it's still significant portion of our medical community is still considering this as controversial entity. It's mainly because of the literature is very confusing. Different groups report mitral annular disjunction using different thresholds, different modality, different patient cohorts, symptomatic and asymptomatic patients, patients with mitral valve disease, patients with ventricular arrhythmia. So different angles of looking at these patients. It's really difficult to understand even the prevalence of this condition. So I think it's important for our societies, both imaging and clinical societies, to come together and define this entity and then define what is the clinically significant entity and how do we follow this patient. So there are a lot of those things still hasn't been worked out. So I would like to see the definition, understanding the prevalence, understanding the natural history and the clinical follow-up and imaging follow-up, all those things that we need to understand about this entity.
Great. And Behzad, what would you like to see in our future understanding of this disease?
So we are in dire need of guidelines in terms of risk assessment for the threshold at which you would intervene to prevent a bad outcome. Right now, we have absolutely no data. And so we all have recognized that the burden of ventricular arrhythmias as recorded by extended monitoring, such as with Holters and loop recorders, can be categorized as trivial, mild, moderate, and severe ventricular arrhythmias. But really, we don't have good data to tell us at what level should you be recommending an ablation? Should you be recommending a defibrillator? It's easy in the patient who's symptomatic. If you've had arrhythmic sounding syncope or aborted cardiac arrest, then it's a no brainer. Those patients are easy to manage. But the majority of patients, thankfully, don't present in that manner, and there's the difficulty. So I think with the development of these large registries, which are going to be following thousands of patients with documented disease of varying degrees over time, eventually I believe we will come to a better understanding of when to intervene. We have many modalities to assess risk currently: historical in terms of age of presentation and history of syncope, ECG findings of inferior T wave inversions, non sustained ventricular arrhythmias, QRS fractionation, and a longer QT have all been identified as potential risk markers. Echocardiography shows you concerning findings in terms of bileaflet prolapse or severe MR, wider disjunction distance, left atrial enlargement, dilating left ventricles, the Pickelhaupt sign by tissue Doppler imaging, and impaired global strain, and then MRI with the burden of LGE, the extent of disjunction. All of these can be used to try and identify where in the spectrum of disease a patient falls. But we still don't know when to intervene for an asymptomatic patient. And I think that is the biggest thing I'm looking forward to in terms of more data being available in the future.
Y'all, this conversation has been super insightful, not just for me. I'm sure our listeners are going to really benefit from all of the discussion we've had about the clinical and imaging components of this super complex phenomenon. Thank you very much from me for coming onto the podcast to have this conversation. Do we have any final thoughts before we close?
I think, it's important to understand that it is a very rare entity and it's very infrequently recognized on imaging. And when we recognize it, it's important to understand that this is not something that every patient is going to have this. There may be every patient may have a small degree of displacement, which we shouldn't really be calling and alerting everybody. I think that's something that we got to be, got to keep in mind. Vast majority of patients with mitral valve prolapse have, benign outcomes. Maybe about less 10% or less than 10% of mitral valve prolapse patients may have bad outcomes. And a small fraction of these patients, when they have bad outcomes, we do not know why. We are thinking perhaps this may be that missing piece, that it's something making some patients at high risk for developing bad outcomes. So I think that's something that we got to think about. It's very commonly recognized. If you're looking for it, we may find it, but not every one of them is going to be pathologic. It's a small fraction is what's going to be pathologic, and how we define that is what is unclear. We think that longer mitral annular disjunction length may be one of the parameters that we could use to identify a subset of patients who may have clinically significant disease. And when we see that, it's important to look for, late gallium enhancement around the mitral valve, and then perhaps think about, characterizing those patients have perhaps have elevated risk for developing cardiac arrhythmias and bad outcomes.
Awesome. Tons to look forward to in the future. And once again, from me, thank you very, very much from the journal. Thank you very, very much from joining us on the podcast. Really, really appreciate your time, Ash, Baskaran, and Behzad.
Thank you so much.
Thank you for having us.
Thank you very much.
Of course. To our listeners out there, thank you as always for tuning in. If you like what you hear from us on the podcast, please rate, review, and subscribe to us. That helps others out there find this awesome content from experts like this. This is the Radiology Cardiothoracic Journal podcast, and we will see you next time.